Okay, hi everyone. Thanks a lot for joining today's webinar, a joint effort of Nutrition International and the Society for Implementation Science for Nutrition. My name is Amandana Arabi, and I'm Vice President of the Global Technical Services and Chief Technical Advisor at Nutrition International. And I have the honor of welcoming all of you to this webinar today. The title is Addressing Real Needs, the critical role of implementation research in designing and operationalizing adolescent nutrition programs. So starting from a little bit of background about the Nutrition International, for those of you who may not be familiar with our organization, we are a global nutrition organization headquartered in Canada. We have offices in 10 countries. We provide technical assistance in more than 20 countries. We have programming that affects in more than 60 countries, and we estimate that we reach about more than 500 million people a year. And we focus on programming in interventions that are specifically addressing nutrition and health outcomes for the most vulnerable. Next slide, please. Just to give you an idea of areas that Nutrition International invests in and our interventions and platforms. For adolescent girls, especially as it relates to this seminar, our interventions include weekly iron and folic acid supplementations or VFAs and nutrition education. And we do this through school-based programs as well as community outreach for out-of-school kids. We also have interventions for pregnant and postpartum women, including also early infant and young children, such as maternal nutrition supplementation, including iron and folate supplementation, birth packages, again, mostly through the health system, but also through a community outreach and behavior change communication. We also have interventions for infants and young children. Vitamin A supplementation has been one of our biggest programs, and supported by the government of Canada as well as other partners. And then we have zinc and ORS and IYCN, infant and young child nutrition. And for all population groups, we also focus on food fortification and salt hydration. Next slide, please. I wanted to show you an overall framework that we use for our own programming, but I felt it would be very relevant for today's conversation and the role of implementation science in improving programming in general in nutrition and specifically for adolescents nutrition. We call this the evidence to action framework. And if you look at the top dark yellow or orange color sections, there are different stages to these programming cycles. We have to identify what works. So this is done with different types of evidence, such as efficacy trials, systematic reviews, and these are mostly coming through research studies and in the literature. And we make sure, of course, we are aware of those and we are aware of the updates in the guidance and intervention effect sizes. And then we move to designing robust interventions that then benefit from that evidence and allow us to bring the evidence quickly to the field implementation. We also use then different programming models to prove implementation success. And then eventually we have to also generate evidence of impact and build this information needed for scaling up at different levels, country, region, and global. And at the same time, this is a cycle. So all of these program learnings goes back into basic evidence and affects how we design our work. Another aspect of this graphic is that program quality is also at the center. So there are different, again, tools and approaches that we have to making sure that we have the highest quality in our programs and assure the quality of implementation as well. And we feel that the role of implementation science is critical in all of these stages and allows us to do a better job of having the highest quality, most impactful, and relevant interventions to those who are most. Next, please. So coming to the adolescent nutrition, which is the topic today, just some background for you. 16% of the world's population is falling within this age group, which is 1.2 billion girls and boys. After infancy, adolescence is the most rapid period of growth for the highest needs nutritionally. For example, ages 15 to 19 have the highest total energy requirements compared to any age group. And higher needs for micronutrients such as iron, vitamin D, calcium, and zinc. And another aspect is the fact that we are seeing both undernutrition and obesity and overweight as at the level of public health concerns in many low and middle income countries. Next, please. Again, another snapshot of what we know about the diets and the nutrition of adolescents. Some examples here. Poor diets in general are driving malnutrition of different types. 50% of adolescent girls in low and middle income countries do not eat 3 meals per day. They skip breakfast, for example. And, again, this could be a proxy for, of course, as we said, they have the highest energy needs. So it's probably also indicating that they may not be receiving adequate nutrition. 40% of girls in Latin America and Caribbean, for example, consume fast foods daily. And then 46% of adolescents in East Asia and Pacific do not eat enough fruits and vegetables. So there is a lot to be done for nutrition of adolescents. And while, again, today we are focusing a lot of the conversation on adolescent girls, with this slide, I also wanted to bring attention to the fact that these numbers and issues don't just relate to girls, but we also have to think about adolescent boys and really this age group as an important age group for nutrition programs. Next, please. For iron deficiency anemia, just to give you a sense of the scope of the problem, the disability-adjusted life years estimated that are lost because of iron deficiency anemia are quite high, as you see in this graph, and in comparison to other potential health issues. So again, at least for adolescent girls, we see that definitely the impact and the public health impact of the iron deficiency anemia alone is quite significant. Next, please. So also giving you a picture of our adolescent nutrition programming and partnerships that we've built in order to be able to implement these programs, I wanted to show you a map. So as you see, NI has been focusing on programming in different regions and areas of the world, but there's still a lot more to be done. And of course, we are looking forward to also hearing from our guest speakers about how these programs were implemented, what are some lessons learned, and also how we can work together as a global community in the future beyond just what NI is doing in its programs, but learn from each other and really increase the impact of everything that we are collectively are doing for adolescents. Next, please. Some of the lessons learned for me as I was thinking about the role of implementation science and how to frame this conversation, I looked at some of the lessons learned from our own implementation, those programs that I showed you on the map. And some of these topics are emerging, and for me, they are also starting to already form an implementation research agenda, perhaps not even just for NI, but globally for all of us to think about as the critical issues in program implementation for adolescents. For example, we found out that adherence and participation is highly linked to school attendance for a school-based delivery. And, again, and especially in this age group, perhaps attendance is also something that's a lot more in the control of adolescents themselves, and there are different factors affected to school attendance. Peer adolescent girl leaders have had a key role. So the peer impact, both positively and negatively, is something that really needs to be looked at. Teachers as leaders and as helps and basically for engaged partners in program implementation, and also all the upstream work that you need to do, especially in programs that are school-based, to bring the ministers of education and health together. These have proven to be critical for success. And then for reaching out of the school girls, of course, this remains to be a challenging topic, and they're a lot more difficult to reach to. At the same time, we know that potentially these girls are the most vulnerable. They're the ones who already are vulnerable because they're not going to school, but also nutritional needs are not going to be met, and they won't be able to be reached through more school-based interventions. So we have to have a specific hard-to-reach approaches developed, and these are resource-intensive. When you do the costing, it does come as being more costly. So how are we going to implement? What type of implementation research would allow us to identify programs that are scalable? That's a big question for us. And then low levels of adolescent access to health systems in general for preventive services and intervention. So this is, again, something that's important for nutrition, critical for reaching these vulnerable adolescent girls, but also a bigger health and nutrition issue, and even human rights and gender and equality issue that we need to also address. And I feel that, again, this is an implementation research agenda from the Nutrition International. We're committed to constantly improving and expanding the scale and scope of our programs. And we are hoping that today's conversation will allow us to have a better understanding of what works and what are some of the remaining research questions. Thank you very much, and handing over to my colleague to start the discussion.
Thank you, Mandana, for your opening remarks and setting the stage for today's webinar. My name is Chaudhary Jalal, and I'm a Senior Technical Advisor, Evaluation and Strategic Research at Nutrition International, and I'm also the CSIN's Continuous Education and Capacity Building Counselor. Just a little housekeeping before I introduce to our guest speakers. Today's webinar is scheduled to finish at 11 a.m. Eastern Time. Over the next 30 minutes, you will hear 3 presentations of real-life application of implementation research. After these presentations, you will have an opportunity to pose your questions during a 15 to 20 minutes discussion period. To that end, please type your questions or comments into the chat box in your GoToWebinar control panel. You may submit your questions at any time during the webinar. Myself and my colleague Shivani Sharma will pose as many questions as possible to our speakers as the time allows. If you experience any technical issues, please also type in your questions and our staff will help you resolve them. We're also active on Twitter, and we encourage you to chat and engage with us through our Twitter hashtag, which will appear in the chat box. It's hashtag #InvestInIR. Finally, a recording of the webinar and the presentation slides will be made available after the session. Now it's my pleasure to introduce to our guest speakers. Our first speaker is Jamie Lee. Jamie is an independent consultant specialized in applied research that addresses operational challenges in international health and nutrition. His work in this field is relevant to several broad communities of practice, including implementation science, human-centered design, and aid effectiveness. Jamie has more than 25 years of experience with community health, nutrition, and social development activities in Africa and Asia. Today, he'll share his experience with us that focus using the focused ethnographic study to inform the integration of adolescent nutrition into multiple sector programs. Our second speaker is Ermias Mekuria. Ermias is a senior program officer with Nutrition International working in Ethiopia. He has worked with Nutrition International in various roles since 2013. Ermias holds a master's in public health in epidemiology from Addis Ababa University. He played a major role in the design and implementation of the WIFOS program for adolescents in Ethiopia, which he will be presenting on today. Our final speaker is Jen Hatchard. Jen is a technical advisor for maternal neonatal health and nutrition in Nutrition International headquarters. She supports the technical quality of NI's M&HN program globally, focusing on women's right to quality essential nutrition services delivered during the antenatal, interpartum, and postnatal periods. Jen is a registered dietitian with an MPH in community nutrition global health from University of Toronto. She has over 7 years experience in international and domestic public health nutrition, supporting the implementation of programs and research. So without further ado, I would like to welcome Jamie. Jamie, over to you.
Right. So thank you for that introduction. As Jalal mentioned, I'll be talking today about the use of the focused ethnographic study, or FES method, in assisting with the design of programming for adolescent girls. What you see there on the screen in red is the title under which the work that I'm going to discuss today was actually published. The field work for the study was done in late 2016, early 2017, and published online in 2019. I'm afraid I'll probably be rushing through some of these slides a little bit, given the time constraints. I will try and linger a little more on the finding slides towards the middle and the end of the presentation. Okay. So just a little bit about what the FES consists of. I mean, it's many things, and it's kind of, it does shape shift a little bit from topic to topic and setting to setting, but the sort of the immutable elements of this of the sort of study method are that it's almost always iterative. That is, it takes place in a number of different phases, and that phasing allows findings to be rolled into the study as it goes along. It tends to be very small compared to survey work, prioritizing the quality of the interviewing, and through that trying to elicit motivations in particular around the use or interest of various interventions in the health and nutrition space. And it's mixed methods. And that usually means some combination of ethnographic style interviewing, long form interviewing, with a kind of open-ended approach, combined with some structured data collection that's often quicker and shorter and more systematic. These are things like listing, rating, ranking, sorting, ways of managing the kind of information that's coming up in the ethnographic interviews. So the combination of those two things in a kind of combined with the iterative approach, it allows these things to sometimes oscillate and mix in quite a flexible approach. But these are the main key points. In terms of our study, our FES had a kind of dual function. We did want primarily to find out what it could tell us about the kind of needs in terms of understandings, beliefs, practices around the nutrition in a population of adolescent girls in Bangladesh. But we were also interested in trying to see, and I won't talk too much about this today, but I just wanted you to understand the broader context was also an effort to see how the FES could be paired with other approaches to model an approach to planning integration. So that other approach is this program impact pathway approach. So the idea there was that the pathways would be discovered that would show the main interactions in BRAC programming between adolescent girls and the various elements of the programs. And the FES would be paired with that to understand more about the quality of the interactions that were there, either on paper or actually in practice. But there's a way that the kind of efficiency and quality of interactions between girls and these pathways could be kind of illustrated, I guess. And as I say, this was the opportunity we had was to take advantage of BRAC's multi-sectoral programming. BRAC is a huge NGO in Bangladesh, and which has just a huge amount of programming and many ways that communities are reached, not just through nutrition, but community development, legal rights, and various other things. The way our program or our study was organized was to do a first phase of key informant interviews and focus groups. That was probably about a week's work. And then we went away and designed our instruments. We implemented them through a second phase, which was a sample of 23 girls, and this was quite a long interview, about 2.5 hours, which included both some of the ethnographic approaches I was telling you, but also free listing. And then that was followed with a third phase, which was less interviewing and more structured data collection. And the sample there was another group of adolescent school-going girls, but also family members of those girls, and that was mums and dads in the same families. Right, and the topics there you can see, this was divided up into kind of 8 interview modules, and some of the key issues that were investigated there was this idea of what girls could remember that they had eaten in the last 24 hours, ideas that they had about health, healthy foods, iron, anemia, nutrition, ways that they received nutrition messages, whether they felt they were important or even feasible, and also just more broadly, the things that they were doing to maintain their health. That's not a kind of exhaustive list of what we were interviewing about, but it's kind of some of the key issues. So we come now to the findings. What you'll see
you have
here.
2 minutes, Jamie.
2 minutes. Oh my goodness. Okay. All right. So I'm going to be really rushing through this. On the left, you'll see in the red are the kind of findings, and on the right, you'll see the implications. We found that there was really a very limited range of places that girls were actually receiving health information and nutrition information, and they were limited mainly to the school and to the home. And they placed quite a bit of importance on books. The kind of implications of that are not totally surprising, but it was useful to know that there weren't a lot of other channels by which they seemed to be receiving this type of information. We were interested also in the social and spatial elements of their habits, and we found that they were involved in preparing food at home, and they did have some agency over what they were eating. And from that, we concluded that BCC could be directed directly to them as well as to the adults who are to some extent controlling what they eat. Also, the consumption was mainly in the home and in the school. In fact, almost entirely in the home and in the school. So there wasn't a situation where kids were gathering socially and hanging out and eating. So really but the social element was quite important, and we felt that was worth noting. We looked at iron consumption ideas. Not iron consumption ideas, but ideas that girls had about what was iron rich and what was not. I'm not going to go through this now because we only have a couple of seconds. But what the main takeaway was that they had some things right. They had some things wrong in that they thought there were some foods which were iron rich that weren't. But a critical sort of strategic gap was that they believed that some really available, accessible, and commonly eaten iron-rich foods were not rich in iron, and we felt that was a strategic gap, particularly these small fish. Diets were, by and large, well balanced. I think about 91% of girls had access in the last 24 hours to some form of iron-rich food, and over 60%, I think I'm right, had more than two sources of iron of animal source food. Excuse me. So if there were, to the extent there are deficiencies, and I think there are, these were arising somewhere else, some sort of interference with absorption, or more likely even the quantities that they were consuming. Snacks were eaten at the school, and there really wasn't a school lunch. They didn't bring lunch from home. They didn't buy lunch at home, but they did buy snacks. So we felt like a fortified snack might be an interesting option. And one of the key things was that they were customarily girls had been encouraged to reduce fish consumption during menstruation. So when you combine that with what I showed you in the previous slide, which was about the misunderstanding that fish were not iron rich, we thought that was an interesting possible issue. And although there was a sense from girls that this practice might be falling out of observance, it might something they associated with advice from older people, I think there were quite a few girls who were starting to say they weren't sure this was actually worth doing. So BCC could accelerate that. How are we doing, Jalal? Can I keep going?
Let's finish it as quickly as possible.
Okay, right. So there is within this population quite a few words or expressions or terms that might equate to the idea of anemia. They certainly, Raktasholpota was the most common. They were all some way of describing blood insufficiency was typically the way it was characterized. So the link with diet in anemia is understood, but the link with iron is less clear to this population. So we think BCC could do a better job of making that connection. So girls know that healthy foods are important. They also know that healthy foods are important for anemia. But the animal source foods of iron are not usually included when you ask them what are healthy foods. So it seems kind of an obvious problem, but there it is. We felt that could be addressed through behavior change messaging. And lastly, there was not a great deal of involvement, it seemed to us, of traditional healers or others outside the formal health sector in the treatment or identification of anemia or Rokta-Shulpota. And that was a bit of a surprise because, using the same approach, this FES approach, in a different population of younger girls to investigate infant young child feeding, we found a great deal of resort to these other non-formal forms of therapy and advice. Right, so final slide, I think. I'm just going to put it all out here because we don't have time to go through it, individually. But that's kind of a sum up of what you saw in the earlier slides. Probably I don't have time, Jalal, to kind of highlight each of these things individually. Thank you. Sorry about rushing through that.
Thank you, Jamie. Now over to Ermias. Go ahead.
Yeah, I'll be talking in 8 minutes about the use of implementation research on translating the WHO guideline to projects and programs. This is the lesson learned from Ethiopia, a demonstration project conducted in 2016 and 17. Yeah, on the background, we are working on the guideline developed by WHO in 2011, that is intermittent iron folic acid supplementation in menstruating women, that is a weekly iron folic acid supplementation. This intervention is a proven high impact and cost-effective intervention. The proven is as evidenced from 10 countries from Asia and Latin America. And this weekly iron folic supplementation intervention has about 4 or 5 core components. That is, the first one is the supplement composition, that's 60 milligram elemental iron. That's the supplementation composition should be 60 milligram elemental iron with 2.8 milligram folic acid. That should be based on the availability of the supplement. The frequency is 1 supplement per week. The duration is 3 months supplementation followed by 3 months off, and then the supplementation should restart. The target group is all menstruating adolescent girls when the population, when the anemia prevalence in the population is 20% and above. So in Ethiopia, anemia among adolescent girls is a public health problem. That is nearly 20% and above. Having that, the Ethiopian government recognized the importance of weekly iron folic supplementation for adolescent girls. However, in 2016, there was no national program implementation framework for the implementation of the program. Based on this, Nutrition International and its partners designed a demonstration project with the objective to test and demonstrate the effectiveness of weekly iron folic supplementation and the nutrition education interventions for in-school and out-of-school adolescent girls. Specific objectives include to identify effective delivery modalities to reach adolescent girls with weekly iron folic supplementation and nutrition education from the multiple practical delivery modalities which employed during the demonstration project, both in agrarian and pastoralist context of the country. When it comes to the implementation research methods, first we conducted formative research. The formative research aimed to inform the design of the implementation and also to develop materials and tools both for the agrarian and pastoralist context of the country. The formative research provide evidence, give us give us an insight to understand the implementing organization, that is the peripheral component of the intervention, that is the weekly unemployment supplementation, and also to understand the enabling environment in the stakeholder dynamics, and also the beneficiaries and key intermediaries around for this intervention. We employed multiple for qualitative data collection tools, history review to understand the national and global policy and program documents about weekly iron folate supplementation, and also other important adolescent nutrition programs. We also use in-depth interview to collect data from the staff, selected staff from Ministry of Health and Ministry of Education, and also health extension workers, healthcare providers, and also school teachers, which also and also key influencers and community structures at Kavali and at grassroots level. We had also a focus group discussion with beneficiaries, that's in school adolescent girls and out of school adolescents, and we also to try to include in school based on the focus group discussion. The lessons we learned from the formative research, I selected those identified as uneven and those identified as barriers. The availability of national and global policy and strategic documents are one of the key enabling identified enablers. There are also multiple practical deliverables, which is identified from the WHO program experience documents. There was also supportive government structures and delivery platforms, such as the school, the community and the health capacity, and also the ability of multiple nutrition corporation is also found to be an identified enabler. Pediatrics and female counselors at schools also, and the availability of community structures at the grassroots levels, at women development groups, at the agrarian setting, and the trained TTBS at the pastoralist setting, and also it is very poor, but the availability of school health service for students by health extension workers from the nearby health posts also can be considered as one of the enablers identified from the formative research which we conducted. And also adolescents, Ministry of Health and Ministry of Education staffs at all levels believed trained teachers can provide. That is, we planned to do task shift for teachers proposed to be providers of weekly iron folate supplementation and nutrition education for in-school adolescent girls.
You have 2 minutes left.
Yeah, the barriers are poor interaction with their system. That's especially for out of school adolescent girls. Key activities employed are we 6 field officers deployed to provide hands-on technical assistance for the implementing team. We capacitated and motivated the key intermediaries through trainings and material distribution. We first procured and distributed to targeted schools and health posts. Fidelity monitoring activities done with program learning to capture key lessons from the implementation process. The service delivered in 74 schools and 53 health posts using 148 trained teachers and 100 trained frontline health workers. At the school, we employed a combination of delivery modalities, that's observed delivery modalities throughout the school calendar, and take-home delivery modality as an alternative approach during the semester break and during the fasting. Girls delivery modality for those in school adolescent girls with irregular school attendance. The coverage, when we see the coverage in the acceptance rate is quite promising. It's about 88%, and When we come to the effectiveness, that is the client outcome, we measure the outcome through the adherence level of 12 plus with fast consumption, both for in-school and out-of-school adolescents. As you see from the slide, it is very promising. From the implementation process, we also captured key lessons. Those key lessons are categorized as barriers and facilitators. From the barrier side is lack of basic student especially safe is one of the key barriers. Poor school attendance, that is absenteeism, is reported to be the main reason for poor adherence, especially by in-school schools. Misconception, refusal, bullying might happen during the first, already happened during the, especially in the first 3 to 4 weeks of the service delivery. Motivation and engagement of homeroom teachers and girls, and also boys involvement, multiple condition found to be a facilitator for the effective implementation of weekly iron folate supplementation in Ethiopia. Generally, the project provides, as a conclusion, the project provides evidence of reach, accessibility, and adoption for the program components, and for it can be scaled up subnationally and nationally. So, using the revised implementation model based on the key findings captured from the demonstration project, we scaled up the program implementation from since November 2017 with into additional 68 orders and nearly 400,000 adolescent girls benefited with 24 plus with fast consumption. The implementation model was also endorsed by the key partners, especially UNICEF and World Vision, and they are supporting more than 100 workers since 2019 to scale up weekly iron folate supplementation for adolescent girls in Ethiopia. This project helped us to change this. So in Ethiopia, change this code. So in Ethiopia, we have evidence-based implementation of evidence-based weekly iron folate supplementation for adolescent girls. Thank you, Jala. Thank you, everybody, for.
Thank you, Amias. Jan Hatchett, please.
So hello, everyone. Thank you so much, Jalal, for the introduction earlier. And I'd like to thank the organizers so much for having me today. Under a previous role at NI, I had the opportunity to provide technical project management of a process evaluation of an innovative and novel program called Girl-Powered Nutrition. And I'm really excited to share with you this example of a pilot program which was able to use the results of implementation research to make meaningful improvements before scale up. So the outline for my presentation today is as follows. I'll describe for you what the Girl-Powered Nutrition Program, or GPN program, is, take you through the results of its external process evaluation, and go through some of the improvements made to the program based on the results of that evaluation, as well as some key lessons learned about working with adolescent girls on designing and implementing their own programs. So this slide is just to briefly introduce the key organizations involved in developing, implementing, and evaluating the GPN program. You've already been introduced to NI, and in 2017, we were able to partner with the World Association of Girl Guides and Girl Scouts, or WAGs, to create the GPN program. And many of you will know WAGs, maybe even from personal experience and involvement, but for those who don't, it provides a non-formal educational approach to provide valuable learning experiences. And just to note that prior to the GPN program, WAGs did not have any nutrition programming. And finally, Universalia is a consultancy firm based in Montreal, which NI commissioned to complete the external process evaluation. So what is the GPN program? For those of you who are familiar with Girl Guiding and Girl Scouting, or even Boy Scouting, you know that once you complete a learning experience, which can include curriculum and activities, you get a badge. So the GPN program is of this non-formal educational model, and you can see what the badge looks like actually on the right-hand side of the screen there. So the GPN pilot got going in 2018 in 4 countries, Madagascar, Sri Lanka, Tanzania, and the Philippines. And the ultimate aim of the program is for girls to feel empowered to take action to break the intergenerational cycle of malnutrition. And I just wanted to spend a moment on the co-creation process that was used while designing the GPM program, as this proved to be a really exciting and eye-opening experience. And I think both NI and WAGs learned a lot about how valuable it is to give this process the time and energy it requires and deserves. So co-creation is an evidence-based process, which includes girls in every stage of problem solving so that a solution is created that can specifically meet her needs. And during the GPN design, co-creation teams were put together in each of the pilot countries with girls across all age groups. And there was quite a bit of feedback in the evaluation around the co-creation process specifically, which I'll discuss later in the presentation. But overall, all parties agreed that this process was essential and resulted in desirable outcomes for both the quality of the design as well as girls' self-esteem. So we wanted to commission a process evaluation of the GPM pilot, as this was a new venture for both partners with great potential for replication. And the major goal of the evaluation was to learn what was working and what needed improvement to inform the scale up, or even for future similar programming from this external, unbiased perspective. And just briefly on the methodology that Universalia used, the evaluation was mixed methods, including targeting a number of key informants for interviews and focus group discussions, as outlined in the table, and also analyzed all relevant documentation. So overall, the evaluation was mostly qualitative, augmented by quantitative data, and involved 3 field missions to the Philippines, Madagascar, and Tanzania, and consulted with a total of 303 people. And carrying on with our co-creation theme, girl facilitators were also trained in the methods, ethics, and data collection processes, so they were actually a part of conducting the evaluation of a program that they had a hand in designing, which offered some really interesting learnings as well. So I don't have time to go through each of the good practices and recommendations for improvement that came out of the evaluation, but some highlighted good practices included employing this girl-led process in the design and implementation, attempt to align the global materials with local context and to involve the local community, the positive working relationship between the partners, and the importance of monitoring and evaluation, and how actually a specific role was created to monitor and evaluate this pilot program. And of course, with good practices come recommendations to improve the program, which is what we wanted so that this program could be tailored to best fit the girls as possible. So no surprise you see here that one of the recommendations was to replicate or continue the co-design process in the scale up of the program. However, there were also some areas improvement noted for this process, mainly that the girls were not fully informed of their responsibilities, timing was too limited, and expectations were not managed well around how their feedback and ideas would be included or not. And secondly, while the evaluation acknowledged the curriculum was developed for the different age groups and local context, it still noted some room for improvement there. And of course, more time and more budget, which is often inescapable in our line of work. And that included more time for future curriculum development to fully take advantage of this co-design process, the length of timing for training the leaders, and increased resources required at the country level. And while it was highlighted as a good practice to develop the M&E role for this pilot program, taking that momentum to the next level in terms of a more comprehensive monitoring system was recommended by the evaluation. Also, the engagement of men and boys, as well as parents and other gatekeepers of adolescent nutrition, was noted as an area for possible improvement, as the pilot curriculum contained messages which may have inadvertently reinforced traditional gender roles, such as girls as future mothers and wives. And lastly,
2 minutes.
thank you, Joelle. And lastly, the evaluation recommended that WAGs post the global curriculum online, develop a sustainability plan, and also gave some very specific considerations and realistic recommendations for scale up. So in preparing for this presentation, I actually had the opportunity to speak with 2 key WAG staff about how approximately 1 year later, after this evaluation was completed, they were able to take the recommendations and make improvements to the program or not. So the first major change that they noted was addressing some of the concerns around the co-design process. So other WAGs programs are now utilizing this approach as well, but with some improved features such as a strengthened feedback loop, wherein after each meeting with the girls, the facilitators talk about the ideas that were brought forth during the last meeting and if they would be taken forward and why or why not. They've also revised the curriculum to put more emphasis on gender equality and include boys as well as parents. They've reduced the timing for the training and also posted the training online so that leaders can complete it when it best works for them, but still keeping a close eye on ensuring quality is maintained. And it was also kind of neat that the day I spoke to WAGs just happened to be the day before they were all set to post all the badge curriculum online. So now it is available free of cost and accessible to all. Of course, this is still the global curriculum, but it has been translated into 4 languages, and they have included guidance throughout to help leaders adapt the materials to their local context. And then just lastly, in terms of recommendations which were more difficult to implement, timing and lack of resources will always likely be a challenge for nonprofit organizations. However, they did try to keep the timing issue in mind when doing further target setting. And while WEGs also really appreciated the feedback about improved M&E, this has been difficult for them to implement due to a lack of resources, but also this needed organizational shift in culture for programs which are largely run by volunteers. And in doing all this, we had some key takeaway lessons around working with adolescents on programs they helped to design and implement. And we were able to come up with 6 key lessons learned supported by the evaluation. And these results are actually outlined in a journal article, which will be released in the coming months in Current Developments in Nutrition. So please keep your eye out for that. So in conclusion, the 3 key points I'd like to highlight from my presentation are that firstly, this co-design process is really valuable. It's a worthwhile investment, but it's something that requires careful planning and investment of time and energy. Secondly, a well-designed and implemented evaluation can be really powerful in improving programs. And lastly, adolescents are a unique population, and as such, there are unique factors to consider when working with them. So we hope that we've contributed to some program know-how there around effectively working with adolescents. Thank you.
Thank you very much for your engaging presentations. There is still time to type your questions in the question box in the control panel. But first, I would like to take a few moments to reflect on what we have just heard. The 3 presentations brought together examples of some important work that show how implementation research contributes to the design and operationalization of adolescent nutrition programs in different settings. Oftentimes, we think of implementation research as applicable only in capturing what goes on during the implementation, the black box as it has been referred in the implementation literature, and also suggests course corrective measures to improve program implementation. However, without a very good program design, even a heavily invested implementation may not result in the desired success. And that is why having an implementation research embedded earlier in the program design or program development has a critical role in program's effectiveness. It not only provides a good program implementation design, but also adequately informs the process and impact evaluations. All 3 presentations touched upon how implementation research can be used to gather adolescent girls' perspectives in the program design and operationalization. Jamie showed the use of focused ethnographic study in in-depth understanding of girls' perception of diet and healthy food, and how girls can be approached through different programs. This is key. This is a key message to us, as very often we ignore the voices of those who we designed the program for. In the Ethiopia example, we saw that the perspectives and suggestions from both adolescent girls and service providers were used to integrating nutrition, adolescent nutrition within the health and education systems. Even when a global guidance is available, contextualizing in the country setting is critical to effective program implementation. On the other hand, Jan showed that the development of the Girl Power Nutrition Program took a different approach. While the girls' perspectives were not captured through any formal research, their inputs were directly incorporated during the designing of the program. implementation research then captured the implications of that modality of program design in the implementation and suggested further improvement. So, the key takeaway, I think that the presentations pose us to think about a more reality-based designing and operationalization of programs where we can not only contextualize the global or country-specific guidance, but also make it adolescent demand-oriented, adolescent designed, and adolescent owned. Again, thank you, speakers. So now we'll go into the questions. I will first ask a few questions to one question each to the presenters, and then Shibani will ask a few questions from the audience. We're actually running behind time. We're sorry for the delay, but if you can take time to spend maybe 10, 15 minutes to go over the discussion, that will be very much appreciated. So I'll start off with Jamie. Jamie, you said your study was aimed at habits and beliefs of the school-going girls. What findings do you think would or would not apply to out-of-school girls? Jamie.
I do think we would have to be careful about extrapolating some of the findings from what I described there, particularly the kind of range of the diet. I mean, we have the caveat that obviously there is iron deficiency and anemia in Bangladesh, and so notwithstanding the range of access to foods that we discovered, there's clearly a problem. And in addition to that, I think that the conditions that we, particularly through our focus group and key informant interviewing at the start, I think became rapidly clear to us that the conditions faced by out-of-school girls are potentially quite different from those of the in-school girls. Now, what I mean by that is that if you're in school, you're probably not married. One of the things that causes girls to leave school is to get married. And if you've got married, typically what happens is you leave your natal village and you enter the family and the village of your husband, where you're really outside of the protection of your actual kin, your blood kin. And we did hear stories of married girls facing really very different situations, and you almost sense that some of the pampering that goes on of girls in some of the households that we interviewed is almost preparatory to this idea of loss and movement. So once those girls are out of their home, they're away from their mom and dad, they're in another home, they're under the control of a mother-in-law, and in the worst scenarios, sometimes treated as a kind of indentured labor. I think that the conditions faced by those girls are very different. And I think that those differences also have, to some extent, been highlighted by similar work to ours, but with that other population. I'm thinking particularly of the work of Lauren Blum and colleagues, which was published around the same time.
Thank you. Thank you, Jamie. The next question is for Ermias. So what was the impetus for you to conduct an implementation research before applying the WHO global guidance in the health and education system in Ethiopia?
Yeah, it is a very important question. The WHO guideline for intermittent weekly iron folic acid supplementation details more about the essential and indispensable elements of the intervention, that is the weekly iron folic supplementation. In order to adapt the peripheral components of the intervention, we need to conduct an implementation research to understand the adaptable elements, structures, and systems related to this intervention, and also the internal, the implementing organization, and the overall environment to implement this program into the agrarian and pastoral setting of the country, so that without adaptation, the intervention will become as a poor setting, will become to a setting as a poor fit, so that to change this, we need to implement an implementation research to understand the overall peripheral components of the interventions, that is, as I said, the intermediate organization, and also to understand the individuals, both the beneficiaries and also the key intermediaries, which will be to be affected by this intervention.
Great.
Thank you.
Thank you very much, Ermias. And the next question is for Jen. So how did the results of the process evaluation enable WEGs to better tailor the intervention package for the different age groups and countries?
Yeah, thanks, Joel. It's a good question. So the process evaluation didn't actually assess the curriculum, but in terms of for the different age groups, the process evaluation did note that perhaps some of the messages were not appropriate for the younger age groups in terms of their ability to understand. So WEGs was actually able to review that curriculum and better tailor those messages to the younger age groups to make sure it was understandable. Tailoring to the local context was a bit more tricky, and it was noted in the evaluation that further attention was required here. But something I didn't have time to mention during the presentation was that WEGs also did their own internal evaluation of the GPM program, and something a bit more specific that came out of that was ensuring that stakeholders and implementing partners at all levels, so global, national, subnational, were familiar with the landscape analysis that was done in the 4 pilot countries prior to, and making sure that that was much more streamlined and specific to the context in which they're implementing the program. So that's something that they will take up in the future. And then I guess lastly, like the global curriculum is posted online, and as I mentioned, there's guidance and notes throughout about how to better tailor that for local context. For example, if the examples of foods that are given in the curriculum don't align with the local context, the leaders are encouraged to change those food examples. And then where different countries don't have, for example, like a national food guide, the curriculum suggests that they use like the Harvard School Nutrition School Plate. So there are global examples available, but tailoring to local context is kind of in the hands of the leader.
Thank you, Jen. I'll hand over to Shivani for some of the questions coming from audience.
Thank you. Thank you so much, Jalal. So, Jen, I have another question for you. And this question is from Naveen. So, the question is, how do you engage with the government counterpart at various levels while implementing the GPN program? And how do you bring health and education together?
So from my understanding, the WAGS programs utilize the school platform to implement their programs outside of regular scheduled classes, but the GPM program was not integrated into the regular school system as such. However, during the design process, we were able to align the GPM curriculum with curriculums from the MOH and MOE in each pilot country where relevant and where possible. And both WAGS and NI maintain relationships with local ministries, so they were made aware of the program and its evaluation, but it's delivered outside of those systems.
Yeah, thank you so much, Jen. My next question is for James. So the next question is, James, so what other settings or issues has the FES method been applied to?
Okay. Yeah, I'm not sure I can give a comprehensive answer to that, but certainly what I'm aware of is that the originator of this method, one of your CIS and founding charter members, is Gretel Pelto, and the earliest work in this using this approach was done by her using the method. This method was essentially her brainchild, and she started that in the 1990s, working on vitamin A deficiency and acute respiratory infections, and it's that approach was used originally in nutrition, and it it's been applied by people like myself in a less formal way in other settings, including the sort of humanitarian nutrition emergencies, particularly around the kind of the sort of formative work around the design of an outpatient approach to severe acute malnutrition. It was brought by Gretel to GAIN in the 2000s to do work on infant and young child feeding. And I was involved in some of that work also in Bangladesh with her around micronutrient powders and the kind of acceptability of that approach to that population. Currently, I'm working also with Gretel on a study of food safety in northern Nigeria. So it's widely applicable. As I say, I mean the key elements are this iterative approach. And the mix of methods that it employs, and those things can really, with some thought, they can really be tailored almost indefinitely. But there are some resources out there. There have been a couple of attempts to kind of codify the approach with different modules that can be accessed online. So it's been around the world.
Thanks so much, James. So my next question is to Ermias. So this question is from Naveen Podyal again. How do Ethiopia coordinating with WFP to implement VFAs and midday meal program? And what is the scale of midday meal programs in Ethiopia?
Yeah, thank you, Shivani. Honestly, we don't have WFP is not part of our national adolescent nutrition program technical working group during the demonstration project and also during the sub-national scale-up phase. But at lower level, especially in pastoralist setting in Afar, we implemented weekly iron folate supplementation in more than 50% of schools who had meal program, so that we found school meal program is one of the facilitator for effective implementation of weekly iron folate supplementation, so that we submitted this recommendation for the National Nutritional Technical Committee and Working Group, so that this will be started to be considered by key partners like UNICEF. They are started to work with WFP and other partners who are currently working in the pastoralist context of in the pastoral setting for implementation of weekly iron folate supplementation.
Thank you so much, Ermias. Over to you, Jalal.
Thank you, Shivani, and thank you all the presenters for responding to the questions, and the audience for posing your questions and listening to us for some extra time as well. So unfortunately, it looks like we have actually run out of time to have any more questions. But if you have any outstanding questions, you can always post it in the comments, and then we can answer your questions later after the session offline. This is one of the second of the three webinar series that is within the NI-CISN partnership. So there will be one more coming. So please stay tuned and sign up the CISN mailing list if you want to hear more about what's upcoming. NI and CISN are both active on social media, and we welcome your thoughts, comments, and engagement through the Twitter. Once you leave this webinar today, you will receive a brief survey of the webinar, and we appreciate if you would take a moment to provide your feedback. You will also receive a follow-up email in a few days with a link to today's webinar recording and the URL to the PDF of the slides. Finally, before I hand over to Mandana for her closing remarks, I would like to thank all the speakers and our valuable contributors, Mandana, as well as Shivani, and all the audience for listening to us. Mandana, over to you.
Thank you very much, Shalal, and all the speakers and all the support team. And also thanks to all of our audience for also staying an extra 10, 11 minutes with us. I hope that you benefited from this webinar and will be joining our future webinars as well. I also wanted to mention this adolescent nutrition training course that NI has designed and has made openly available to everybody. And we will be sharing the link to that course in this chat box as well. So feel free to go and explore. And we're looking forward to having some of the participants finishing that course and getting the certificate as well. Thank you again. Thanks everybody, and looking forward to seeing you again in our future. Bye.